with us and our two staffs to arrange this subcommittee hearing. I don't think it comes as news to many Americans that our nation faces a crisis in adolescent mental health. At any given time, one in five adolescents are experiencing a mental, developmental, or behavioral disorder. The COVID-19 pandemic placed a heavy burden on young people struggling with their mental health. One survey of high school students found that 44% persistently felt sad or hopeless. In addition to that survey, we know of other surveys that find similar results. We know, for example, that about half of all people who experience a mental health condition begin presenting symptoms by the age of 14, making high school a critical intervention point. The Biden administration and the 117th Congress has recognized the importance of mental health support in our schools and have made critical investments in our communities to this end. It is critical that students, particularly those with disabilities, feel both academically and emotionally supported in their schools. Most schools have some mental health supports in place, like peer support, one-on-one counseling, and outside care referrals. But many students are falling through the cracks. To reach every student, we need all hands on deck. That means far more mental health professionals in making every student, every caregiver, teacher, and school staff member a part of the solution to teen mental health crisis. In 2021, the average ratio of students to school counselors was 415 to 1, despite a recommended ratio of 250 to 1. We cannot expect progress in addressing this crisis without lifting up professionals in such high-impact settings. And we must do more to identify and help secondary students in need of mental health support, especially as they prepare for college. The transition to college is, of course, both exciting but also very stressful, in a very stressful time for our teens. Living away from home and an emotional support system for the first time, it's easy for students to be caught up in their new life and not get the mental health care that they need. When students arrive on campus, they may confront new challenges to adjusting to hectic schedules, making new friends, and keeping up with academic expectations, which can compound feelings of stress and despair. The social isolation of the pandemic left students unprepared for the social transition to college and less likely to establish connections with peers and mentors at school. These forces are compounded for students entering college with a mental health condition. Without supports in place, these students' care can and often does lapse just when they need it the most. The task of navigating a switch to telehealth or finding a new provider in college largely falls on the students and, if available, their parents. Students are left to maneuver the complexities of the healthcare system, including insurance coverage. With a shortage of providers in most areas and many not covered by insurance, finding an affordable and timely care can be very onerous. Data shows that when college students don't get the mental health care that they need, it can lead to major disruptions in their education, as unaddressed mental health needs are associated with poor academic performance and lower rates of degree completion. In a survey conducted in 2021, over 70% of bachelor's and associate degree students who had considered taking a break from school in the past 6 months said emotional stress was an important reason. In order to set students up for success in college, early identification of mental health needs and ready access to treatment are, of course, critical. When students move away from home and transition to college in adult life, continuity of care and reasonable accommodations help them manage new stressors and lead meaningful, productive lives. That kind of support shouldn't be a luxury for students experiencing mental health conditions, but today, unfortunately, it is. Families are getting priced out of timely mental health care, and the evaluations needed for mental health accommodations can cost thousands of dollars out of pocket. Because of gaps in our pediatric mental health care system, many needs are not being addressed until far too late, if at all. So accessing timely mental health care that is covered by insurance shouldn't feel like winning the lottery. It should be the same as getting care for any other health condition. That's why Ranking Member Cassidy and I introduced the Healthcare Capacity for Pediatric Mental Health Act, which would establish grant programs to expand mental health integration, workforce training, and care capacity among providers that treat young people. Senator Cassidy and I also introduced the RISE Act, which would provide information to students with mental health disabilities and their families to help them select the right college and streamline disability documentation requirements so that the cost of repetitive testing is not a barrier to reasonable accommodations. In addition, Senator Portman and I introduced the Investing in Kids Mental Health Act Now, which would provide guidance to states on expanding pediatric mental health care capacity and a Medicaid payment increase for pediatric behavioral health services to strengthen the continuum of care for many children. While we've made strides this Congress to address the mental health crisis among our youngest Americans, it is clear that more work needs to be done. When pediatric emergency departments across the country are overwhelmed with children in need of mental health care, it is a cry for help. Young people experiencing mental health challenges need somewhere to go and get the care they really need in a supportive environment where they can thrive. So I look forward to hearing from today's witnesses about how we can expand mental health support in preparation for and in the transition to college. I'll now turn to Ranking Member Cassidy for his opening statement.
Somewhere there's a teenager who will one day be sitting in that chair and this chair and be speaking of ranking members and chairs and be sitting on the dais, and she or he is our future leader. Our obligation to that person is how do we best equip she or he in order to be the person sitting there or sitting here. Of course, I hope they're all Republicans, but maybe you can only hope for so much. So we have to take that within the context of what we are currently addressing. The context in which we're currently addressing is that 3 years of COVID have just had their toll upon the mental health of adolescents and college students. The isolation that formerly was kind of never there because you were always with others, under COVID, it became so pronounced that those who had issues could not convey them to others, but rather kept them within themselves, and we see, if you will, despair. Now, the statistics bear out the intuition. Suicide, third leading cause of death among those 15 to 24 in 2021. Mental health emergency room visits increased 25% in children, 30% in teens in 2020. And I go back. This is more than a statistic. It is our future. So the question is, how do we care for those teens who are our future? Several people on the dais here, we've worked together. We need to reauthorize the Mental Health Reform Reauthorization Act of 2022, which Senator Murphy and I worked back on in 2016, and we need to reauthorize. It expired in September. There is an urgency here that we need to accomplish. Now, I will point out, since this law passed, all 50 states now have wraparound, coordinated specialty care for teens with early psychosis. Previewing, my question for Dr. Weiss will be, why has the reach been so limited? When we put this in, we wish to have those wraparound services so that when the young person has his first psychotic episode at 16, it is his last psychotic episode, because everything he needs to return him to wholeness is wrapped around, and it becomes a distant memory, but not a life-defining event. We need to ensure that that would occur. We also, as my co-sponsor of the legislation, Senator Casey spoke out, need to help with that transition to college from high school. And again, the Mental Health Reform Reauthorization Act of 2022 can help achieve this. Now, we have had success on, aside from the bill I just talked about, recent success addressing mental health issues. In response to the Uvalde shooting, there are resources that are put in that response bill, which are for troubled youth at risk of suicide, at risk of addiction, of harming others, and other mental health issues that would be in high schools. We have increased access to mental health and crisis intervention services, telemental health, and in-school mental health services. I will just echo what Senator Casey and I just said. Two bills that we have put forward. Healthcare capacity for pediatric mental health access, to increase mental health access outside of hospitals so children can stay at home and don't miss school. The RISE Act. You know, a child will get an IEP in high school, say, for example, for dyslexia. Then they got to get it redone when they go to college. The underlying problem leading to the IEP has not changed. So why are we putting this obstacle as they transition from high school to college? You got to go through it again. If the condition is not permanent, that can be indicated. But usually, for example, with dyslexia, the condition is permanent. And so why do we put obstacles for people to receive the interventions they need as they're on their pathway to be filling these halls to be our future leaders? Now, it is so wonderful. You see young people stepping forward. Ms. Williams, thank you for your example that we will hear of how you've used grief in your life in order to lead people your age to mental health wholeness. An example from my own state, Emma Benoit, who attempted suicide, but after coming out of that, has used her experience and the kind of the process of events that led her to that terrible state to help others, to help her peers avoid it. And that's the way our democracy works, in which it's not just the folks on this dais helping those younger people who are our future leaders, but those younger people providing leadership in of themselves so that they help prepare themselves to be our future leader. With that, I yield.
Thank you, Ranking Member Cassidy. Now we'll turn to our witness introductions. I'll provide several, and Ranking Member Cassidy will provide some as well. Our first witness is Dr. Sharon Hoover. Dr. Hoover is a licensed clinical psychologist and professor at the University of Maryland School of Medicine, Division of Child and Adult Psychiatry. Dr. Hoover is also the co-director of the National Center for School Mental Health and the director of the National Child Traumatic Stress Network's Center for Safe, Supportive Schools. And we want to thank Dr. Hoover for being here. Maybe hadn't had to travel as long as some of the others. We're grateful she could be with us to bring her expertise. For our second and third witnesses, I'll turn to Ranking Member Cassidy.
I get to introduce two people today, two folks from Louisiana. I'll begin with Dr. Curtis Wright. Dr. Wright is a vice president for student affairs at Xavier University in New Orleans. He oversees numerous programs dedicated to improving student life, including education, wellness, campus safety, and athletics. Before joining Xavier, Dr. Wright served as the dean of campus life at Wagner College in New York City and oversaw multicultural affairs at New York University and in-residence education at the University of Arkansas at Little Rock. Dr. Wright earned his BA in sociology, a master's of education in adult education from the University of Arkansas, and a doctorate in higher education management from the University of Pennsylvania. Dr. Wright's experience will allow him to speak with a wealth of knowledge and experience to us. Thank you. Dr. Ashley Weiss. Dr. Weiss is an associate professor of psychiatry and the director of medical student education and psychiatry at Tulane University School of Medicine. She received her Bachelor's of Science at Loyola University in New Orleans and a Master of Public Health at Tulane. Attended medical school at Lake Erie College of Osteopathic Medicine in Florida, returned to New Orleans to do a residency in psychiatry and subspecialty fellowship in child and adolescent psychiatry at Tulane. After developing expertise in caring for the young person's mental health during her medical training, Dr. Weiss built the first comprehensive first episode psychosis care program in New Orleans called Epic NOLA. She also launched CALM, which is a community education campaign to increase people in Louisiana's awareness about emerging psychosis symptoms and available treatment. In my medical practice, I worked in the same setting as Dr. Weiss, taking care of the uninsured and the chronically mentally ill. They would have, I tell you, benefited from your expertise, Dr. Weiss. So I'm grateful that you are here, and we look forward to hearing how your experience and your education can improve the support for our youth. Mr. Casey?
Thank you, Ranking Member Cassidy. Our final witness is Ms. Brooklyn Williams. Brooklyn is a high school senior at Baldwin High School in Pittsburgh, Pennsylvania, where she has founded the CHILL Club, an offshoot of the Allegheny Health Network's CHILL project. The CHILL Club is an open-door mindfulness club aimed at supporting students coping with the stresses and anxieties of high school. Brooklyn, we're very pleased to welcome you here today. So now we'll turn to our witnesses for their opening statements. We'll begin with Dr. Hoover.
Good morning. Thank you. I want to express my thanks to you, Chairman Casey, Ranking Member Cassidy, and to all the members of the subcommittee for inviting me here to speak with you about these important issues and for your commitment to the mental health and well-being of our young people. Again, my name is Sharon Hoover, and I'll be speaking to you today from my perspective as a professor of child and adolescent psychiatry and also the co-director of the National Center for School Mental Health and the National Center for Safe Supportive Schools, both funded by the U.S. Department of Health and Human Services. I'll also speak to you through my lens as a parent of 3 young people, a 9th grader, an 11th grader, and a freshman in college. So these issues are near and dear to my own heart. We are all concerned about the growing mental health needs of our young people. The good news is that there are many strategies and effective programs to support and promote youth mental health and to also support their effective transition from high school to college, and I hope we can get into some of those programs today. I'm going to share 3 important ideas with you this morning. Number 1, invest early in nurturing environments for families and schools. We have incontrovertible evidence that the vast majority of challenges impacting our adolescents and young adults could be prevented by by creating nurturing environments starting early and continuing into middle school and high school and beyond. In Dr. Anthony Bigden's book, The Nurture Effect, he details decades of scientific research into actionable steps to reduce youth problems and to reduce youth problems and to produce caring and productive young people. Just as we were able to reduce the prevalence of smoking decades ago with a national public health movement, at this point in time, we need a relentless public health movement to increase the prevalence of nurturing environments that minimize toxic conditions and promote pro-social behavior in our young people. In the earliest years of children's development, effective family interventions include things like the Incredible Years, nurse-family partnerships, the Triple P parenting program, which exist in many of the states across our nation, but are not really at full scale as they should be. In elementary years and beyond, interventions like family checkup are helpful to support parents as they handle some of the common problems of their children, as they use reinforcement to promote pro-social behavior, as they monitor their children's behavior and help set limits, and as they improve family communication and problem solving. Students who receive the family checkup program in 6th grade are much less likely to be depressed, to use substances, and to actually graduate from high school and to not be arrested by the time they're 18. School-wide systems to minimize punitive interactions and to teach and promote and richly reinforce pro-social behaviors. And these include programs like the Good Behavior Game, like positive behavior interventions and supports, where we have decades of research have demonstrated long-term positive impacts on adolescent risk behavior and engagement in college and career. So first, to optimize the success of our high school and college students, we must invest in nurturing environments at every level of their development. Number 2, establish comprehensive school mental health systems in all schools. This includes supporting the mental health of all students in their classrooms through teaching social and emotional skills and mental health literacy school-wide, and providing mental health interventions where they are in partnership with families in schools. Comprehensive school mental health systems not only improve mental health outcomes for our young people, but they also have, again, demonstrated success in improving really important academic indicators like attendance and grades. In my written testimony, I provide specific examples of policies to advance mental health in schools, such as establishing mental health as a state-required component of K-12 education, like those we see in New York and Virginia, and requiring health plans to reimburse for mental health screenings that are conducted on campus. The Hopeful Futures campaign this year released school mental health report cards across all 50 states and an accompanying legislative guide, and this is a great starting point for policymakers who wish to strengthen school mental health in their own communities, and it's detailed in my written testimony. Number 3, we must equip high school to college transition skills for all of our students, like self-determination, time management, emotion regulation, help seeking, and navigating adversity. And again, we have evidence-based strategies to do all of these. This should begin by middle school and extend into college and include efforts like self-guided modules to support emotional health, free well-being screenings at high school and college campuses, peer-to-peer mental health education and support, and texting warm lines where students can report concerns about themselves or others. For youth with mental health challenges, we need to provide tailored transition supports and person-centered planning, and 2 such exemplary programs include the Renew program, which was developed and studied out of the University of New Hampshire, and a program called Got Transition, developed by the National Alliance to Advance Adolescent Health. I want to thank you again for the time to speak. I look forward to hearing from my fellow panelists and to our further discussion.
Thank you, Dr. Hoover. And now we'll turn to Dr. Wright.
Subcommittee Casey, Chair Casey, Subcommittee Ranking Member Cassidy, and the members of the Committee on Health, Education, Labor, and Pensions Subcommittee on Children and Families. Thank you for the opportunity to testify today. It is an honor and privilege to sit before you this morning as the Vice President for Student Affairs and Interim Vice President for Enrollment Management at Xavier University of Louisiana, the nation's only Black and Catholic institution of higher education. I was asked to testify this morning to address the importance of strengthening the continuum of mental health support for all adolescents, particularly in the years leading up to and during the transition to college. I will do that. And of course, I will also offer a particular lens which allows me to address the issues confronted by those students who choose to matriculate at HBCUs. Chairman Casey, most students who entered Xavier University in August have never known a world without Facebook or war. While I learned how to exit the building in a single file line in preparation for a potential fire, my students have learned how to run, hide, or fight their ways out of an active shooter situation. They are all too familiar with social, political, and racial unrest in this country, and they've probably participated in more marches or rallies than most of us in this room. They have lived through global economic recessions that resulted in family members losing their jobs, homes, and overall financial instability. They are also still in the midst of a global pandemic that caused the entire world to stand still and reimagine what normal looks like. Some of these young people lost multiple family members due to COVID-related illness, in part because they lacked access to affordable health care, and also had family members whose primary source of income meant their status as a frontline worker was non-negotiable. Our students were well acquainted with loss long before the pandemic, as they routinely attended candlelight vigils, memorials, and funerals for friends who died due to gun violence, drug addiction, and suicide. What our students at Xavier experience mirrors what their peers across the country are experiencing. The prevalence of anxiety and depression is rising across the nation, particularly among young people. College students of all ages are more distressed than ever before, and increasing shares are enrolling with mental health histories in terms of diagnosis, treatment, and medication. Institutions like Xavier are challenged to recreate systems of care and support to meet the growing needs of a very different student body. While students and the lived experiences they bring to campus have changed, the funding to take good care of them have not. The number of students seeking help at campus counseling centers have increased almost 40% between 2009 and 2015 and continue to rise until the pandemic began. This is according to data from Penn State University Center for Collegiate Mental Health. We, like so many of our peers, know that we can't do it alone and are developing strategic relationships with our K-12 partners and our parent community. Access to health care, specifically mental health care, is not always readily available to students who come from rural areas, inner cities, or economically depressed communities. Now, most colleges and universities were the direct beneficiary of the CARES Act, the HERF II of the Consolidated Appropriations Act of 2021, and the HERF III authorized by the American Rescue Plan. These critical legislative lifelines allowed us to maintain university life for our students throughout the pandemic. The HBCU bomb threats of 2022 have altered the higher education landscape for every single student studying at an historically Black college to better their lives. For this specific set of institutions, not only to be singled out and threatened repeatedly has caused our students untold mental anguish and stress. Although the prosecution of those who maliciously caused the situation is a law enforcement issue, the impact on our students is not. Specific mental health focus should be directed to us as the sole recipients of these threats. Senator Casey, over 20 years ago, a mentor asked me if I knew the difference between a high school senior and a college freshman. After offering what I considered to be these profound responses, she replied without emotion, 3 months. For incoming students, 3 months is the only things that separate high school from college. Yet we believe that these students should arrive on campus fully prepared to not only make adult decisions, but more importantly, to live within those adult consequences. It's our responsibility to help them navigate the contested intersections of university life. While the landscape as it relates to mental health with young people can appear bleak, I, like my fellow Arkansan President William Jefferson Clinton, still believe in a place called hope. I'm hopeful because of the resilience of our students and the generation from which they've come. However, for them to achieve success, we must dismantle our outdated systems that were not designed for their success. So, Mr. Chair, I want to leave you with some recommendations. First, similar to the guidance offered by the Office of Civil Rights related to Title IX, the Department of Education should consider offering guidance on mental health first aid to support educators and administrators for all K through 16 institutions which receive federal funding. Number two, the Department of Education should extend the funding period for HERF 1, 2, and 3, as well as the HBCU, TCU, and MCI certified funding until August 31st, 2026. Help must push the Senate to redline House Resolution 6893, the Invite HBCU and MSI Act to improve HBCU facilities in response to the HBCU bomb threats and increase a sense of security on our campuses. Number four, financial stress is one of the most prevalent causes of anxiety for students entering college across the country. Congress should continue to advance common sense legislation to reduce the costs of higher education and support President Biden's plan to address college debt through limited student loan forgiveness. And lastly, Congress should follow the lead of Senator Casey and the distinguished gentleman from the great state of Louisiana, Senator Cassidy, and pass the Health Care Capacity Act for Pediatric Mental Health and the RISE Act. It has been an honor to present this testimony, and I thank the committee for addressing this important issue. As a leader in higher education, I know the benefits of early screening, the impact of developing coping strategies, and the importance of empowering families to train their children to become problem solvers. We must address this mental health concern of our youth as the stakes have never been higher, and our collective work should be a priority for every American. I'm grateful to the committee for leaning into this very difficult conversation, and Xavier University of Louisiana stands ready to serve as a resource and community partner. For more information and details regarding my remarks, I ask that you read my written testimony for your review.
Dr. Wright, thanks very much for your testimony. Dr. Weiss.
Thank you for having me here, Chairman Casey and Ranking Member Dr. Cassidy and the rest of the committee. Again, my name is Ashley Weiss. I'm a child and adolescent psychiatrist at Tulane School of Medicine in New Orleans, Louisiana. I specialize in first episode psychosis. Psychosis is a symptom typically associated with the onset of schizophrenia and bipolar disorder. These illnesses can have devastating consequences, from the increased risk of cardiovascular disease and premature death to the ramifications of being chronically marginalized by society. Why am I bringing up illnesses like schizophrenia and hearing about mental health in high school and college students? It's because this is where they start, in our young people, and not by any fault of their own. Adolescence is a time of incredible brain maturation, and for some, this maturing process goes awry, leading to the emergence of severe psychiatric disorders. These illnesses don't discriminate. They were present pre-COVID, and they're still present now with a little bit of a different context. And globally, these illnesses lead to the greatest cost both directly and indirectly. So what is psychosis? Psychosis can be described as a loss of touch with reality. Examples of psychosis symptoms are hallucinations, confusion, and delusions. These experiences start small, like mishearing sounds as voices, or beginning to feel as if people are watching you. This paranoid feeling could turn into a belief, a delusion, where one is convinced the world is literally out to get them. And it is difficult but very necessary to imagine what this might feel like for a young person. Some facts about psychosis. 3 out of 100 people will experience psychosis in their lifetimes, mostly occurring for the first time between ages 16 and 25. For every one person experiencing psychosis, 6 other friends or family are directly impacted. In the US, the average time one experiences psychosis prior to treatment is 72 weeks. Not days, weeks. 1 in 10 will attempt or complete suicide, with the highest risk being after the first episode. So to give these statistics a local context, George Washington University enrollment is about 26,000 students, which means almost 800 will experience psychosis annually and will not receive appropriate care for over a year. Over 4,500 friends and family are impacted. Nearly 80 will attempt or complete suicide. So there is a sense of urgency because time is not on our side. The impact of the brain can be deteriorating. The last 3 decades of research show that specialized intervention as early as possible after psychosis onset improves outcomes across the board. There is no time to wait. The same philosophy is already accepted in stroke intervention and should be accepted in psychosis intervention as well. In 2015, I started the Early Psychosis Intervention Clinic in New Orleans. We've treated nearly 1,000 people since we opened our doors. Our multidisciplinary team provides coordinated specialty care, including medication management from psychiatrists, individual, family, and group therapy, and wellness coaching. All treatment is deeply individualized with the goal of getting young people back on track, and that often means back to school or graduating or to their first job. But what we do in the clinic is not enough. Because of the need for early treatment in psychosis, we're forced to think about early detection. We have a robust early detection campaign called CALM, which was mentioned, and this aims to educate the community about psychosis, debunk myths, reduce stigma, so hopefully people will feel comfortable and safe coming forward for treatment. Our goal is that an individual comes forth on their own, and they don't have to wait for someone else to bring them in, and they certainly don't have to wait for the police to pick them up, having an acute psychosis, and take them to the emergency room. There are significant challenges and barriers that must be considered. For most people, recovery can take many, many months, but time continues to pass for everyone else in their lives. Their friends have often moved on, graduated, moved away to college, or started their first job. They often feel misunderstood, ashamed, quickly leading to the loss of confidence and increased isolation. And there is a conspicuous gap in school-based recognition of these needs for these individuals in keeping them engaged or even welcoming them back after their recovery. I have multiple college students in my program, students in every college in Louisiana, actually, which makes me very proud, who didn't even know that they were eligible for retroactive medical leave that would erase incompletes from their transcripts, who have crushing student loan debt from the semesters that they became ill. And we are often the first place to provide guidance in how to approach these issues. There are financial threats to programs like ours. Although our program is committed to long-term care, most programs like ours don't go beyond 2 to 3 years. We are now realizing that people lose their gains when they lose specialized care, but how do we pay for continued care? We've subsidized our growth through the congressional legislation mandating a portion of the SAMHSA block grant be set aside for early severe mental illness. We appreciate this opportunity because it covers the necessary care that is not covered by insurances. In our state of Louisiana, Medicaid and commercial insurers do not reimburse any of the coordination of care that's required to provide this model. No case management, no record review, no coordination with community partners like schools or hospitals, no treatment team meetings. And without the coordination, the risk of relapse increases exponentially. If commercially insured, patients might have 2 copays a week. That will quickly add up after a month, and that becomes unattainable. People in this age group fall off their parents' insurances and then might not even qualify for Medicaid. And then barriers exist beyond our clinic. There's a pervasive lack of education coupled with ample misinformation about psychosis and what it even is. This gap in education exists in the general public, but extends even to mental health professionals. Psychosis is not a topic in health education curriculums for high school or college students, even though their age group is most at risk. Psychosis education is not a prominent part of the curriculum for those interfacing with high-risk groups. Psychosis intervention is far from being considered an essential part.
Doctor, we have to wrap up.
Okay. Can I have a 10-second wrap-up?
Sure.
Okay. I'm here today to say out loud for the record that our youth and young adults are the vulnerable ones to these illnesses, and we cannot ignore this fact as a society any longer. These illnesses are not curable, but they should not be associated with an inevitable lack of productivity and institutionalization. They're not preventable, but there are strategies to mitigate risks, such as early detection. They're manageable, but management does not mean doing the bare minimum. That approach has not served us well historically, and we need to do better for our people. It's a necessity for them. We must be ambitious in our commitment to these youth and young adults so that their recovery is supported while they explore their opportunities that they deserve and expand their futures.
Doctor, thanks very much. We'll conclude now with Brooklyn Williams.
Senator Casey, Senator Cassidy, thank you for listening to my story, and everyone else here, thank you for listening to my testimony. Looking at me, you might not suspect that I'm dealing with a lot of internal struggles. I'm speaking in public, so you might not suspect that I have severe social anxiety. I cover my eye bags so no one tells that I struggle with insomnia. I ate my entire breakfast this morning, but I still have bulimia, and I got out of bed and did my hair so I do not look depressed. Just because I do not fit the description of someone with mental health problems, that does not mean that I'm fine, and I feel like we as a society overlook people with these health issues because they do not fit into the concrete mold in the textbooks of mental health symptoms. There is a fluidity in the way each of us experience mental health, and I feel like schools and communities only intervene when it becomes intensely severe or, in unfortunate cases, too late. In my experience, mental health highs and lows happen in waves, always sporadic, and most recently due to being a high school senior in my last year of childhood. As a child, I do not remember feeling there was any disordered thinking in my life, yet looking back on it, I feel that mental health was not ever a topic of conversation at school or home until I was a teen. When I was 13, my mom passed away from stage 4 metastatic breast cancer after a 10-year-long battle with the disease. Losing her devastated my family, and I felt like a portion of myself died with her. As much as I loved my dad and my siblings, my mom was my lifeline and my best friend, and although we tried to prepare as much as possible for her passing, it was the worst feeling that I've ever experienced. The following year was a blur of numbness and therapy sessions, but the pandemic caused everything to shut down, and I felt alone. To combat those feelings of grief, depression, and of isolation, I started to paint and do crafts to cope. It helped me express and lose myself in an activity rather than sulk in my emotions. Once school started up again, I thought if this is making me feel better, then maybe it'll make others feel better too. So I started the Chill Club, where we do activities like meditation, yoga, crafts, and painting every month as a group to come together and talk about our shared emotions and not worry about the problems in our lives. From starting my club 2 years ago, I've been graced with many opportunities that helped me to share my story and cope with the loss of my mom and the struggles resulting from that, but I feel there's a long way to go. Incorporating mental health topics from an early age would be the first stepping stone I would take to support people's needs. Talking about these issues with teens before they are reaching for help. Providing more accessible outreach professionals in schools, having all students speak to these professionals and not only the ones that come for help. Allowing for mental health absent days to be excused, just like having physical illnesses because mental health and physical health are equally as important. Allowing for anonymous assistance would also be effective because it is evident that most teens do not want to ask for help publicly. Lastly, professionals working with teenagers should be more open and equipped to talk about mental health struggles by being provided with the correct necessities to help teens work through their problems. As a high school senior, I've grown to see that the process of moving from adolescence to adulthood is tricky enough with college essays, picking a major, and knowing that I'll leave my childhood behind. So providing teens with accessible professionals to speak with will only benefit our communities. Everyone needs to be aware of their mental health because it's not selective or to be stigmatized or to be put aside because it's too hard to understand. Working through these issues will not only give opportunities for teens to grow and flourish into adults, but also to allow our communities to be stronger as we improve the way of life one kid at a time. Thank you.
Well, Ms. Williams, thanks very much for your testimony, and I want to thank the testimony of all of our witnesses, and especially to you for demonstrating uncommon courage at any age, but we've rarely heard testimony like the testimony you presented today, so we're thankful that you're here with us. I'll start a round of questions. I'll just do one question to expedite our schedule a little bit. I'll start with Dr. Wright. In your testimony, you described how a large number of students at your university are struggling with mental health. Given that around half of mental health conditions begin by age 14, it's likely that many of the challenges that you're seeing, of course, started long before college. In addition to school staff, parents can be a child's strongest advocate to help with getting the needed support that they require. But these families, these parents need to know what to watch out for in their children. How should we begin engaging families so that they're aware of the signs that their child may have a mental health, developmental, or learning disability?
Thank you, Senator. That's an amazingly profound question. And when you think about the intersections of our students and their families, where they're coming from, right? So many of our students come with these undiagnosed challenges. So when they first have their first moment, we don't know what to do, and neither do they. And so I really believe that the work that you all are advancing in the in your bill, the Pediatric Access Act, will help with that, because providing more touch points, training folks from the very beginning, having mental health first aid in our high schools and our elementary schools, but also in our community centers and our churches, right? Faith communities, right? I think so many of our families have been told that mental health is a secret, right? And they won't allow their students, their kids, to get help. So we've got to create some level of understanding that mental health is tantamount to having diabetes, right? If someone has a heart attack, we don't keep them hidden away. We rush them to the hospital. And when someone is having these symptoms, we need to do it. So removing the stigma of mental health is one of the first things, but then educating their parents on how to connect them with folks in the community. In rural spaces, that might be harder. So working with them in their schools, with their counselors, working with them in some spaces in their housing authority places, or their therapists or their counselors there. But I do think being able to expand the reach of qualified mental health professionals in these spaces will allow those parents to see those warning signs, because many of our students' parents may not have been trained to know what to look for. But providing schools, community organizations, resources to help them, I think will be essential in that.
Great. Doctor, thank you very much. I'll turn to Ranking Member Cassidy. I'll reclaim some of my time later.
I will defer to Senator Tuberville and allow a colleague to go.
Thank you very much. Thank you for being here today. This is important. I don't think people really know how important it is. I coached for 40 years. I coached in 8 states. I went in high schools all over this country. In 80s and 90s, we had a mental health problem. But after 2000, after the internet and this thing right here came out, it's devastated our kids, and I saw it every day. So this is a huge problem. It's going to get worse before it gets better. Dr. Wright, I'm like you, faith-based, family. I mean, that's how we're going to overcome a lot of this. It's going to have to come through that, but we've got to be prepared, and we've got to be able to recognize the problem. Dr. Hoover, for years, I saw kids come play for me, and a lot of them came in early in my career with very little problems. The last 20 years, they came in and they had ADHD. They said they did. And we were giving them drugs right and left. We weren't. The doctors were prescribing them. Do we have a medication problem in this country when it comes to mental health?
It's a good question. And first of all, Senator Tuberville, I want to thank you for your coaching years, because we know that all of the adults, as was said earlier by Chair Casey, all of the adults have a responsibility to take care of the mental health of our young people, including our coaches. I was on a plane yesterday next to a school bus driver and was telling her that she has one of the most important jobs when it comes to actually supporting the everyday experience of our young people and their mental health. In terms of medication and the diagnoses that seem to be increasing, part of it, I would argue, is really that we are just becoming more aware of the mental health needs of our young people. I would say that our medications are far from perfect. In fact, many would argue that they are imperfect solutions to the mental health challenges of our young people. But there is also strong evidence that some of the medications for our children and adolescents, including for ADHD, as you mentioned, and other mental health challenges, have been effective. But they are most effective when combined with other interventions. And that includes mental health interventions provided by licensed counselors, social workers, and psychologists, but also the everyday supports, whether it's from the faith community, from families, or from schools. So it's not a one-size-fits-all approach, and it is not a one-intervention approach. In fact, most of the data would agree that medication combined with other interventions is probably the most effective for some of our most debilitating disorders.
Thank you. Dr. Weiss, we locked these kids down for several years. Fortunately, in Alabama, we didn't do as much. And, we had a study come out not too long ago. We went from 49th to 39th. In some areas of our scores improving. We went from 40th in the country to first in the country in graduation rate because we stayed in school. My question is, we've already spent so much money on a lot of these problems. In your opinion, how do we best direct these funds in the future to help with mental health?
I have to, full disclosure, I'm from Alabama and grew up with Auburn football. So.
Oh, you did good.
Yeah.
I should have asked you the first question, too.
The work that I do is addressing, severe mental illnesses that have long been underfunded. We don't have a good track record historically of taking care of those with the most severe mental illnesses, and they really weren't given opportunities to complete school, to go to higher education. So now we have them actually getting well after their first episode with a severe illness, just like you could get well with diabetes diagnosis early, just like you could get well with other major medical problems. And so the cost needs to be reflective and encompass what it takes to scaffold them into these opportunities that they really haven't had before. And that might be more costly than to support a kid with ADHD from high school to college. However, we're just really learning now in the last 10 years what that's going to look like for this country. So, because early intervention in severe mental illnesses is such a new concept. And literally, we're talking about the last, 10 years of clinics, last 20 years of research.
Dr. Hoover, I know we're talking about going from high school to college. Half the kids in this country don't go to college. They get a job, they get in the military. How do we help them? How do we evaluate them? Because most kids that go to college get some kind of evaluation through the process of higher education. How do we help those kids that don't go to college?
It's a great question. And when I saw the subject of today's hearing, I was hoping that it would go beyond just college, because we know so many young people don't go on to college. And I would wish that we had better supports in place for them. I mean, I do think it really speaks to the first issue that was brought up, that we need to start earlier. The supports that we're talking about from high school to college are critical, but what's more critical is that we put systems in place from pre-K to K through 12 to actually identify and provide scaffolding and structured support for their mental health. And that doesn't just mean, I mean, I think our young panelist, as usual, said it best, which was we can't wait until there's a crisis. We can't wait until things get really bad to provide services. We need to be doing mental health literacy in the classroom. We need to be putting systems of identification into their hands, whether it's in schools, on college campuses, or in their communities. I think the efforts to support integration into primary care are critical. So for those who do go on to career, maybe not college, they can get some of those same supports in their primary care setting or in other natural settings, whether that's their faith community, whether that's their family. There are many interventions that can support families to better equip them to support their young people, including as they transition to adulthood. So we need to not just put these services in schools or primary care, but we need to put them in the hands of families.
Dr. Wright, you got a comment on any of that about kids that don't go to college? You see a lot of those.
We do, and just in community in general. And I think, as she was describing, being able to have them access those resources in other spaces, right? There's dignity and honor in all work, but sometimes we privilege, right, this transition, my profession. But being able to make sure that they have access to an affordable health care so that they can afford to take advantage of that, whether it's through state-sponsored Medicaid or private insurance. But I do think that being able to recognize that we all live within the context of our lives and learn within the context of our lives, that there's support in their spaces of work and worship, and they have the ability to talk with their family, because again, secrets are the things that kill us. And so, but yeah, I absolutely agree with what she said.
Thank you.
Mm-hmm.
Thank you, Senator Tuberville. We'll turn next to Senator Smith.
Well, thank you, Senator Casey, and to Senator Cassidy, who I believe had to leave for pulling this together. I really appreciate it. It's a great panel. So I think the people here in this room today believe that mental health care is health care, and that every young person deserves access to the mental health care that they need. And yet I think we also know that we fail in that mission, though we're working hard on it. And everybody in this room, I think in one way or another on this side, has been working to expand access to mental health care in schools. I certainly have, with legislation that I've introduced. So let me ask you, Ms. Williams, if I could. So I first realized that I was suffering from depression when I was in college. I'm quite sure now that I was having that experience when I was in high school, but I didn't quite understand what was going on. I didn't really see how it was incapacitating me. And so, and I'm quite sure now that my experience wasn't unique. It seems like with physical health care, we do a lot of thinking around preventative care and early intervention, but yet what happens with mental health care is you get to a crisis point where you are really incapacitated, and then you're sort of starting from behind, right? So I'm wondering if you could just say from your perspective, like what that might look like in a high school setting where you are getting at people's challenges earlier rather than later.
Yeah, so I feel like in my experience, I was behind, like how you said. I started becoming really low in my depressive state before I thought to seek help. But I feel like nowadays there's a lot more, it's a lot more noticeable because of like social media or being online and talking, like people just like say anything nowadays, and they talk about all the things in their lives. So like really just getting out there and saying that they're not feeling like the way they should or something, it really brings out the topic more. But I feel like starting at a young age, I feel like that would be a lot more beneficial for kids to learn about what's going on and start seeing the signs. And if they don't feel like they want to go outside or go to school or not feel the way they should feel, or they feel like they might be a little bit different, they should always have someone to talk to. And I feel like the first step to do that is to get everyone like the care they need beforehand, so nothing will escalate and get too great that no one can control it. And unfortunately, there's so many cases of like suicides and like people going to psychiatric wards and stuff like that because they haven't got the help that they needed. And I've definitely seen that in my personal life. There's a lot of kids in my surrounding schools and even in my school that have lost their battle to depression or anxiety and stuff. And I feel like that should be a lot more preventable if we take the steps to reach out to therapists and get them into schools more, because I definitely see that like we have a school therapist at my school, but there's not that many people that even are aware that there's a school therapist or have access or know the way to get to the therapy that they need, or talk to the counselors, because there are thousands of kids inside one school at one time, and there's like 4 or 5 counselors for those thousands of kids.
Right, right. So part of it is not having enough providers of therapy in schools, and part of it is making sure that people see the pathway from the way that they're feeling to the help that's there that they might not even realize is there.
Yes.
Right. Let me just ask, really, any of the other panelists. I'm very interested in how we can integrate physical health care and mental health care in a doctor's office setting too, in the pediatric level. What kind of integration can we do there? And I'm just wondering if you have any insight for us as we think about that, because it seems to me that a lot of folks, assuming they have access to health care, and God knows not everybody in this country does have access to health care, physical health care, kind of what we've seen. Maybe Dr. Hoover, you'd like to address that.
I'd be happy to. Thank you for the question. And I appreciate you asking, again, our youngest member of the panel first, because I think when we speak to our youth about kind of their ideas of how we can get services and supports to them, they usually have the best answers. So with respect to better integration into primary care, first of all, it can happen out in our pediatric mental health clinics and our young adult clinics. We often have this bifurcation. It's a really artificial bifurcation between pediatric medical care and adult medical care. I would argue that we shouldn't just drop young people off at the age of 18 and say that they have to switch to an adult provider. That's number one. But in terms of integration into primary care, it can happen both in those healthcare settings, but also in healthcare settings in schools, school-based health centers. I appreciate the investment in school-based healthcare. More young people are able to access primary care when it is offered in the context of school-based health, whether it's out in the community in primary care or in the context of a school-based health center. We have wonderful examples of mental health, behavioral health providers situated in those settings. But we also have many examples, especially in our more rural or smaller campuses where they don't have the provider network to be situated physically in the building. We actually have wonderful examples of effectively using telemental health to integrate right there into the mental health, into the primary care setting. And the last thing I'll note is just the increased investment in the child psychiatry access programs, are now called the primary care, the mental health and primary care access, where you have primary care providers that can pick up a phone or get on tele and actually reach out to a specialty mental health provider, have been instrumental. So I really appreciate the expanded coverage of that. We've seen it not only in primary care be critical, but also in the context of schools.
Thank you. Chair Casey, I know I'm out of time. I'm going to submit for the record a question that I have also around the sort of proliferation of mental health care apps, and I'm trying to understand the efficacy of those and what kinds of consumer protections we need to think about for those. Thank you very much.
Thank you, Senator Smith. I'll turn next to Ranking Member Cassidy.
Thank you, Senator Casey. Thank you, Senator Cassidy. And again, thanks to all of our panel for being here, and especially Ms. Williams. Thank you to you for coming. You're absolutely the most courageous person I'll meet today to come and share your story. You may be the most courageous person I'll meet all week and all month. And I got a question for you in a second. My first question is going to be for Dr. Weiss and Dr. Hoover. Prior authorization, access to care has been a bigger issue. It's the number one physician administrative concern in America. As an obstetrician, I saw the issue delay care for infertility patients, for high-risk patients. My friends in orthopedic surgery tell me that it's getting harder and harder to get the joint replaced, and maybe the process delays it 3 or 4 months' time, and meanwhile we get the patient addicted to narcotics. So I'm just curious, in your clinical experience, when it comes to mental health issues, are you seeing any challenges in the prior authorization realm? Dr. Weiss, why don't you go first?
It is mind-numbing.
Mind-numbing.
Yes. Our clinic bills for services, and we also, have some, money that subsidizes what's not covered. But even the services that are covered, and I deal with a lot of antipsychotic medication, long-acting antipsychotic injectables that are not preferred on formulary, but that are the best medications of certain classes of medications that are more appropriate for young patients versus the older ones for many, many reasons, like less side effects. And it will take weeks sometimes. Getting prior authorization for community-based mental health services can sometimes take weeks, and then every 3 months they want you to repeat the authorization. In Louisiana, Medicaid has been privatized, so there are 5 companies that provide Medicaid services, each requiring a different type of pre-authorization or prior authorization for services. So this is the job of 2 or 3 people. We have a census of about 170, so it's hard to finance that, because I am, aware that businesses need to be financed in a fiscally responsible manner, but the amount of administrative support you need to get these things done is astronomical.
Yeah. Dr. Hoover, would you anything to add?
The only thing I would add is I certainly agree with everything you said, and yet, of course, we need some authorization in place, especially for our most vulnerable youth who may, for example, experience polypharmacy. Young people in the foster care system, for example, we know may be on multiple medications. There needs to be some authorization and process for understanding the medications that they have been prescribed, so that it's done responsibly. But the wait times for getting into mental health care, as you said, mind-numbing, astronomical, and for families can be really impossible to navigate.
My experience is what was most frustrating is after my nurses had spent days and days in the back and forth with faxes, not emails or online, but faxes, eventually I get to talk to a person. And maybe it was a neurologist trying to explain to me why we shouldn't be using progesterone for preterm. Do you ever have that same frustration? I wouldn't begin to want to tell you the drugs you should be using.
Yeah, I left inpatient work specifically because of this. I would be told that someone didn't qualify for inpatient psychiatric hospitalization because they weren't actively trying to kill themselves or someone else. And I'd say, so what about hearing the demon coming to get you? Then you can't even get out of your bed or go to your house or eat food. You don't qualify for inpatient services. And I just want to reassure you that we do have legislation that we could get across the finish line that would impact Medicare, this prior authorization issue. Yeah. And then we'll go after CHIP and Medicaid and some of those others. I'm running out of time. I want to go to Dr. Wright and Ms. Williams for a second as well. One of the tragedies in this country is fentanyl poisoning. And this is an editorial written by a mom from Kansas who lost her son, Cooper Davis, a little bit over a year ago, a 16-year-old who ordered a half of a Percocet tablet via Snapchat, unknowingly laced with fentanyl, and the child died. Dr. Wright, are you seeing any problems with the high-risk group we're talking about? I'm afraid often turns they're trying to find Xanax or Adderalls or uppers, downers, and they're being laced with fentanyl. Are you seeing any of this in your world, Dr. Wright?
Specifically at my institution, no, we don't see, that's not the drug of choice for our student population. However, prior to Xavier, I lived in Staten Island, and I worked at a private liberal Liberal Arts College on Staten Island, where we saw a huge problem with the drugs that were laced with, right? Students whose prescriptions had lapsed, and so now they're going out and finding other ways. And so, yeah, that is a huge problem that our young people are dealing with. It's partly because, as Senator Tuberville said, they can't medicate it, and now they don't have access to those medicines now, and they're trying to find it any way they can. But it is a growing problem, particularly for students who are trying to
Thank
take
you.
care of themselves.
Ms. Williams, and I certainly don't want to get too personal. I always tell my patients you can pass on any of my questions, but do you see any problems? Are students able to find those types of things online? Do you see it in your school, or any concerns about it?
You mean drugs?
Specifically, fake pills laced with fentanyl. Like, people are trying to find Xanax or Adderall, and my goodness, it's been laced with fentanyl.
Never in my experience have I heard of anyone doing that. No.
Okay. All right. Well, thank you so much. Dr. Weiss, anything to add?
I think one thing that you bring up is important, that every community is different in terms of what very emergent substance use problem is going on. You know, in New Orleans, we have a major problem with synthetics and people smoking mojo and becoming psychotic, and to the point that you can't get them well. It's just a fake marijuana. I can buy it in a grocery store. I mean, and it can ruin your kidneys. So you have to be attentive to what's happening in different areas for sure.
Senator Marshall, thank you. We'll next turn to Senator Kaine.
Well, thanks to Senator Casey and Cassidy for pulling this together. And what a great panel. I want to talk a little bit about before college, and then I want to talk about the transition to college. I spent Thanksgiving with family and friends, and one of the friends I spent time with is an administrator in the St. John County, Florida school system, which includes St. Augustine, and her responsibility includes all the guidance counselors. And she was telling me, we don't have enough, and they're doing college guidance and helping people with financial aid forms and trying to be counselors, and there's some Florida laws now that are making it even harder because they can't talk about everything with the student without letting parents know. But setting that aside, the point she was making is there's just not enough people here. So, Ms. Williams, let me just ask you, you go to Baldwin High School in Pittsburgh. How big is Baldwin High School? How many kids?
There's like 1,400, but it's also with the middle school and high school.
So that's all together.
Yeah.
When you decided, hey, I need to seek help from somebody because of the many issues I'm dealing with, and as you described, death of your mom and COVID, and there's so many, where did you go, and was it easy to get help, or was it hard to get help?
It was, I don't know, I think I did it the wrong way, but I went to my principal first because I was having trouble with like just trying to get to school and get to do the things I wanted to do with my friends and everything. So I went to the principal first because I was closer to him because I didn't have the same guidance counselor all years of my high school.
Oh, you were getting assigned a different one?
Yeah.
Yeah.
There was, I think I've had 5 in the past 4 years, so it was just a little
And is that some because you get assigned a different one each year, but also just there's some turnover and people coming in and out?
Yeah, it's we were supposed to have like the same one all 4 years, but because of like COVID and everything, and some people taking maternity leave and different things like that, it was just not consistent. So we just didn't have the same.
Let me ask Dr. Hoover a question. I'm going to come back to you in a minute about college, Ms. Williams. Dr. Hoover, do you think families utilize the IEP process sufficiently to help children deal with, emotional and mental health issues? I've been a mayor and worked with my school system and real familiar with IEPs. One of my 3 kids had an IEP. But, commonly for something like a speech therapy or, a very narrowly defined learning disability, families can use the IEP process for getting accommodations for students to deal with emotional and mental health issues. Do you think we use that enough in the K-12 space?
Thank you, Senator Kaine, for the question and for your support of mental health in schools. So the simple answer is yes, families can use the IEP process. And no, they don't use it probably as often or as well as they should have, in part because they're not often aware of how to do it. They don't have the family peer support to help them navigate the process. Of course,
And to
there's
the extent
stigma.
that there's still any stigma about mental health issues too, that would probably be an additional
Hugely
barrier,
detrimental.
right?
But the other point I want to make, so we need to increase awareness, decrease stigma about using special education accommodations to support mental, emotional, behavioral issues. But we also need to provide supports that go outside of or beyond the special education system. There are a lot of young people who could get mental health supports in schools that would not require an IEP, but they
Yep.
could still get mental health support in schools.
Now I want to go over to the college side. So Ms. Williams, you're a senior. So are you thinking about going to college next year?
Yes.
So when you go to college with the experience you've had, and you've now found some support systems that have helped you, and you've created support systems that have helped others, but you're going to show up on a campus where, like, you'll be one of maybe hundreds or thousands, and you'll be kind of a free agent day one. What are you going to do when you go to college to try to make sure you have the services that you need? And I ask you this because there might be a lot of people just like you listening to this hearing that would want to hear the way you're going to do it, since you've been appropriately sort of assertive in trying to find the help that you need.
Right. So I'm thinking about like joining different clubs and different social settings that will help me with mental health, and other people that like deal with the same things that I deal with, and different groups like that deal with kids with a parent that passes, or person that deals with depression or anxiety or something like that. So I wanted to join different groups, but I've also talked with my therapist a bit about how to transition from her being like my child therapist to becoming like having an adult therapist. So what we were planning on doing is like overlapping sort of the time
Good.
between like her like leaving my life and having a new therapist, so we can so she can like talk me through the way I should like interact with the new therapist, and try to overlap them and try to I don't know, like get away through the process
transition.
easier, like
Yeah.
transition easier.
That's good advice for others. And Mr. Chair, could I ask one more question of Dr. Wright? We've had two really tough situations in Virginia in recent years. One when I was governor, a tragic shooting at Virginia Tech, and then recently a tragic shooting on the University of Virginia campus. And in both instances, there's some differences, and I don't want to make them sound exactly similar when they're not. But in both instances, the individuals who carried out these grievous crimes had tough high school years, but had found supports in high school where they were able to be successful students, successful athletes. But then when they went to college, it was like none of that information that helped them succeed in the high school setting, it's like none of it went to the university setting. And in each instance, and we're still learning more about the University of Virginia situation, it seems like was sort of a downward spiral, and maybe partly because they didn't have the support services surrounding them that knew their situation and knew how to help them succeed when they were in high school. So the RISE Act, which you all have introduced, would take, if somebody has an IEP, it would take that information from high school and not just make it easier for them to continue it in a university setting, but it would also transfer the knowledge about how to help this young person succeed to the college setting. But how do you deal with that in your institution, this coming into a place where you're brand new and it's all, you were expecting you after 3 months to be an independent adult and make good choices, and maybe you have a past history that doesn't really, it's not aware, it's not made known to anybody on campus. So how do you help students in that transition at Xavier?
Sure. So there's peer-to-peer training that we conduct so that the freshmen are paired with what we call peer deans, who are upper-class students who help connect them to not only the social side of university life, but also those resources that will help them navigate the university. We also think about those spaces where students are going and try to marry. So we know that students are going to see our campus ministry office, right? So training those folks to be able to help identify when they hear things, get them to counseling. Similarly, doing that same work in the classroom, because sometimes faculty will interact with students, and they'll see something in a report that they've written, or they'll come to them and they'll say, I missed class today because of X.
Right.
Or they'll also let us know when they start to see things that are different. But I do think that one of the most important things that we've been doing is really engaging our students' parents. We want to respect them as full adults, but we also recognize that we can't do it without a full support system for them. And so working with those parents will oftentimes get us information that we didn't know that will then help us connect with their previous therapist.
Thank you for that. I appreciate your letting me go over.
Thank you, Senator Kane. Senator Cassidy.
That's right. Just to follow up the kind of same thread as did Senator Kane. And I think this is more for the audience watching, so I just want you to kind of document by your testimony. If somebody does have an IEP as in a high school, and they're trying to transfer to Xavier or another university, are you able to access that information at all? Can you access it but know there's difficulty in terms of utilizing or using that information? Can you comment on that, please?
We can't access it unless they give it to us, right? So they have to bring it to us, and then when they bring it to us, even if it's outdated, what we will do is provisionally provide those accommodations and set them up with a coordinated care plan to get them the evaluations that they need. But unless they bring it to us, we don't have access to that because in our admissions process, we're not allowed to ask them information about their mental health. Doctor?
I was just going to add, and what you, I think, demonstrated so beautifully is that, when there is a mental health team involved with a high school student that's going to be transitioning to college or to a job, whatever they want, we're very aware of what is going on the senior year of high school. And so we're sort of anticipating and preparing ahead of time of where they're planning on going, the application process. I've had to read a lot of personal statements for college applications. We've already identified the key players in their new community, whether it's they need a first episode program in their community. We've already reached out to them. We don't have.
Excuse me, what you're telling me is that best practice is that the high school counselor would then be seeking a HIPAA form release that she or he could send the information to the college, and the college could just, again, continue that sort of enveloping,
Yes.
we're going to support you.
Correct.
Now, do you have a sense of
And you
how
can
often
be
this-
clear about what you're.
But hang on, do you have a sense of how often this best practice is actually implemented?
Very little.
Very little. I mean, it's.
Now, is it not implemented well or implemented so little? Is that the problem of the university, or is that the problem of the high school? Oh, what is going on here?
I think that there's many things going on depending on what the situation is that you're dealing with. If it's an academic disability, then it would be.
No, but we're speaking specifically of mental health.
Mental health.
Now, by the way, our RISE Act, if you have dyslexia, that doesn't change with lifetime forever you're dyslexic. So that's easily taken over.
Right.
Mental health is obviously a different issue.
Right.
So again, if you had to tell us, what's the problem between the person who's helping someone like Ms. Williams, sending that information to the college to which she chooses to attend, and then that seamlessly moving into the counseling that she needs? Because if not, it ends up with the tragic consequences that Senator Kane just referred to. What's the problem there? What can we do?
Coordinating care from both sides.
Yes, ma'am, I get that. But
People
what
answering
is
the
the mechanism where we
phones.
force that marriage, if you will? It sounds like it's just not happening. And it sounds like it's just not happening because, is it too strong to say, a lack of effort? Dr. Hoover?
Well, I would just say that we have to have some protections in place for healthcare privacy.
Now, but
and
HIPAA, signing a HIPAA form would be.
That's exactly right. So we need to educate our young people as they transition to adulthood about their privacy rights and how to sign the
Let me stop you,
HIPAA
Dr.
form.
Hoover, because that really should be, I'm a healthcare doctor.
Yep.
And so if somebody comes to me and I know they're moving to another state, I say, listen, I need to send your records to Mississippi, and I need you to sign this form. I don't think it's incumbent upon the patient to understand that there's a form which she needs to sign.
But it's incumbent upon them to understand whether they would wish to. A lot of college students, one of the biggest hindrances of college
Okay,
students
stop
to
for a second.
actually getting services is because they don't necessarily know or want those services when they get to college.
But we're
campuses.
we're talking about something different. What we're talking about, because Dr. Wright, I think, spoke of, and Dr. We spoke of proactively reaching out. But that suggests that they've been informed that there is an issue.
Correct.
Now, I'll say that the nice thing about somebody being 17 or 18, mama's still there.
Correct.
And I find that mamas are, like, we couldn't live without them. But she can come in and make sure, dear, I know that you need to sign this form, and I'm going to sign it with you if you're a minor, and we're going to send those records. I'm not sure I'm going to accept the excuse that the student is unaware. Yeah, that's true.
Not an excuse. I just think they need to be educated, and
But I
I
do think that
wholeheartedly
the initial
agree.
sending of that record should be incumbent upon the guidance counselor or the social worker or whomever.
With the permission of the family.
Exactly.
Absolutely.
So I think what I'm pushing, but what I'm not quite sure I'm receiving a yes, that's true from, is there a problem? Is there a lack of follow through on the behalf of the typical high school guidance counselor or social worker to trigger that?
Yes.
Yes.
Okay. Now, is there likewise a sufficient, insufficient pull through? The university gets it. But what do we do with it? Oh, that's great. Put it in the file.
Yes.
As opposed to we are going to jump on this and make sure it doesn't happen.
And there's often a requirement for reassessment, which, as you alluded to earlier, is often completely unnecessary.
Right.
Right.
So our RISE addresses some of this.
Absolutely.
By this, I hope all my colleagues now will become co-sponsors. But there's also, beyond federal law, there is the lack of awareness on the high school and the university as to their respective roles.
Correct. Senator, it's a skill versus will. Can we or will we? And can we? Absolutely, we can. But I do think that we sometimes hide behind policies, right, that will limit what we will do. And
Oh, I totally get you, Dr. Wright. Oh, my gosh, people retreat because they're just so scared of their shadow and they use that as an excuse.
Right.
It's an incredible frustration of mine.
Right. But I do think the RISE Act would help provide some federal guidance on what we should be doing, right? And
But it's
so-
more than that, and I don't quite know what it is. It's probably,
Well, I think clinically, if you're a clinically astute therapist with a high schooler, then you should be talking about these things, and it shouldn't be the day before you go, oh, let's send your mental health information. It should be this whole transition, what's going to happen to make them feel safe and comfortable with continuing their mental health care in the next phase of their life. And
well, I
this
will
is
say
how
on
we're
a
gonna
federal
do it.
level, there are some times that we can do best practices and we judge different organizations by best practices.
Mm-hmm.
And can you do an audit of your charts and see how many X, Y, and Z? So I just say that for my colleagues for us to start thinking about. I'm out of time. I actually had other questions for you all, but I will submit those for the records, particularly for you, Dr. Weiss, as regards how you're using the wraparound services and the need to augment Medicaid, which just seems crazy. But we'll get back to you. We'll send you a letter for the record. Thank you.
Thank you, Senator Cassidy, and I know we have to wrap up soon, but I'll exercise a chairman's prerogative by just adding maybe one more question for Brooklyn Williams. But to our three doctors, if you can each, if you want to, provide anything else for the record that you hope we would have on the record in 30 seconds to 1 minute each, if you can do that. This is kind of a quick lightning round before I'll wrap up with Brooklyn, then we'll do our closings.
Glad to. So the one thing that I want to emphasize is that while we do need to invest in child mental health specialists and increase the numbers of counselors in schools, psychologists, et cetera, we really do need to make it that every adult and peer has education and training to support mental health. And that can be through things like mental health first aid and youth mental health first aid. There's also a free federally funded mental health training for all educators called Classroom Wellbeing Information and Strategies for Educators, or classroom-wise. We have many tools at our fingertips to train everybody in the system, and that would include in mental health literacy in the K through 12 curriculum. We can't rely solely on mental health specialists to cure our way out of this mental health crisis.
Thanks, Dr. Hoover. Dr. Wright.
I also want to echo Dr. Hoover in the need for mental health first aid. As someone who has sat and attended far too many funerals of students over the course of my career who had bright, brilliant futures but weren't able to see that, this is an important conversation, and I'm so grateful to the committee for engaging in it. But we also need to recognize that the teacher preparation should involve a certain level of understanding how to navigate these spaces because they're the front line. So thank you.
Thank you. Thank you, Dr. Wright. Dr. Weiss?
I echo as well and think that this mental health first aid should also include specific and more severe illnesses and not just be a generic approach because dealing with some of these more misunderstood mental health conditions can be very challenging for someone that doesn't have the background. And I just want to stress that while we talk about early intervention, we have to think about early detection and beyond schools, like to the communities.
Doctor, thanks very much. I'm told, Senator Kane, you had something you wanted to say?
If I could just quick, and this is back to Senator Cassidy, this point on best practices. A university probably wouldn't want to try to get a student's medical record before the student was admitted because the student and family might wonder, well, wow, maybe they'll turn me down if they see something in my medical record they don't like. But once a university admits a student, the first letter that goes out is, hey, you've been admitted, and here's the deposit you have to put down. And it has a whole lot of other information in it. And that letter from a college could say, we can help provide services on day one that will help your students succeed if we know as much as we can about what services help the student succeed in high school. If you will fill out this HIPAA form and send it back to us, we can get the school's full record, not just the transcript, but the full record, so we can do that. So the RISE Act is a really good one, but I also think there's best practices at that moment. Everybody is going to eagerly devour that letter. You're in, and here's the deposit, but here's information. And that's a good moment to have that discussion. So I just kind of wanted to put that on the record for anybody from colleges that might be listening to this hearing.
Good point. Well, Brooklyn, you're going to be the last answer of the hearing, but I want to particularly thank you for not only being here, that's difficult enough. I could never do what you're doing when I was your age, not even close. But also, as much as it's inspiring to have you here and to hear your testimony and to listen to the answers to questions, your story, what you've had to overcome personally, is not just inspiring to people here, but will inspire countless young people across the country. So we want to commend you for that. And I guess sometimes we don't, often we don't listen enough here in Washington. We don't take enough time to hear the perspectives of young people. So I guess just by way of conclusion, what would you hope that we would hear? What point do you want to make before we conclude?
I would say just try to take advantage of the young people that want to come and work with you guys, and just try to get them to reach out to the people around their age more, because talking to people that are around your age is a lot, I'd say, easier than trying to talk to people that have not grown up the same way you have. And there's a lot of different experiences from when everyone here was younger than whenever I'm me now, being a 17-year-old in 2022. I'd say just having more ears and having the constant communication is very beneficial. Without that, I feel like there's a lot there'd be a lot less good in what we're trying to accomplish. And I just wanted to say thank you for letting me talk amongst these doctors and all of you, very insightful, professional people. It's just a really nice experience, and I'm eternally grateful.
Brooklyn, thanks so much. We're honored by your presence, as we are by all of our witnesses. I'll have a closing statement, and then I'll turn to Ranking Member Cassidy for his. We know that in today's hearing, we heard very, very powerful testimony about how to address the crisis in adolescent mental health and set our nation's young people up for success in college and life. We also discussed creating systems of comprehensive mental health support in schools and communities to identify and respond to unprecedented mental health needs among our young people. We also talked about gaps in the continuum of mental health care that must be filled through care integration, health workforce development in a greater variety of timely care options. Long before the pandemic, there was a significant rise in mental health conditions among our nation's young people. Their mental health challenges have only been exacerbated by isolation and stress in recent years. Too many of our young people are not able to show up as their full selves. To fully enjoy the many experiences that make high school and college special, and too often they don't have that opportunity to perform at their best and to achieve meaningful goals. Young people across our country have unbounded potential and their whole lives ahead of them, and yet suicide is the second leading cause of death among people ages 10 to 14, and the third leading cause of death among young people ages 15 to 24. We can't accept this. We must do more. We must do more here in Washington and across the country to help get young people the support they need. Congress must continue to support successful programs and legislation like those we've talked about today, and I look forward to working with my colleagues to achieve that and to make sure that young people have the future that they deserve. So I'll turn to Ranking Member Cassidy for his closing remarks.
Very briefly, thank you all. What a great conference. In one sense, oh my gosh, there's so much to do. But there are tangible things that could be done that came out of this. Ms. Williams, your example of youth groups, peer-to-peer, if you will, helping others. The whole conversation regarding pre-authorization and how that could be better. And the whole idea that maybe we could have Medicaid provide those sorts of services, those kind of coordination services, that therefore the SAMHSA grant would not be used for a lower calling, if you will, but could be a higher level of service. Dr. Wright, thank you so much for Xavier doing best practices. Dr. Weiss, too, as regards how to take a child who's leaving high school and those 3 months later enrolling. Dr. Hoover, you're kind of seeing the whole spectrum. Thank you all. I think what we learned from this is a set of measures that, if taken, can make the situation better. And there is nothing more we could have asked for from this hearing. Thank you once more.
Thank you, Ranking Member Cassidy, and thanks for your work in helping us arrange this hearing. I wanted to first, before we conclude, also, in addition to thanking each of our witnesses for their testimony and their presence here today, I also want to ask unanimous consent to add 2 statements to the record, and I'll describe them. The first is a statement from the Children's Hospital Association on the need to ensure children and adolescents receive the mental and behavioral health services they need to prepare them for healthy young adulthood. The second is an excerpt from the 2020 National Survey on Drug Use and Health that includes current statistics on substance use, mental health, and treatment among adolescents. So ordered that they are made part of the record. If any senators have additional questions for the witnesses or statements to be added, the hearing record will be kept open for 7 days until next Wednesday, December the 7th. Thank you all for participating. This concludes today's hearing.